this side and see. So, oh, that's right.
Sorry.
Okay, brilliant. Okay, so it's examination skills, isn't it? But actually, examination starts with the history. So actually, most of what you're going to expect to find, you should have already got from your history alone. So you have an 80% sort of suspicion of what's going on already just from taking a detailed history. The history will basically be pain with stiffness or not stiffness or instability. If they come with instability, you hone in quite easily on what you'll need to find out in your examination, because you're trying to rule out whether this is a traumatic injury that's causing instability or is it inherent instability that they've got. But I'll cover that again later on. Okay, so general examination textbooks tell us, orthopods anyway, look, feel, move. Okay, so look, feel is very straightforward. You're looking for any scars, you're looking for any muscle wasting, and you're looking for any lumps and bumps. So the lumps and bumps I normally look for are the most common ones, the AC joint. If it's dislocated or arthritic, it's quite prominent. The sternoclavicular joint can also be quite prominent sometimes, particularly if it's arthritic. Winging of the scapula is the other thing. Okay, but everything else, all that common really. Wasting, so the wasting you're trying to look for is supraspinatus, the infraspinatus. So if they've got a tear or dysfunction because of a neurological disorder, they'll become wasted and you'll get a bigger divot on one side compared to the other side. So always compare both sides. So the next important thing is the move, really. Okay, so again, all the other groups that have been through here, we were talking about what they thought would be the first thing you would test for in movement, and most people would say, lift your arm up. Okay, but we've been trying to tell all the groups that actually that's the least useful movement, because almost everyone that comes into your office will say, I've got shoulder pain and it hurts when I lift my arm up. So you already know that. So when they lift the arm up, they're going to have pain, aren't they? So you're trying to differentiate what the cause of the pain is. And one of the easiest movements that will at least differentiate, or at least tell you what, exclude some diagnosis, really is external rotation. So that's what we think you should all start off with first. Okay. So if he now, face the patient and then say, tuck your elbows into your sides and then rotate your forearms outwards, the external rotates equally on both sides. So he's got normal external rotation, but what if he said the external rotation and this one stopped there and that one went full? What's going through your head? What could this be? So you haven't got a full diagnosis yet, but you've already started to think, what could this be? What stops you from external rotating? Okay, that's top of my list already, so I'm already thinking, right, this guy might have a frozen shoulder. Anything else? Which rotator?
Like an external.
Yeah, external rotator, infraspinatus.
Yeah.
Okay, so that's one thing that might stop him from external rotating. Anything else? So how do you differentiate between frozen shoulder and an infraspinatus tear? Passive movement. So that was an active movement. So if I passively externally rotate him now and he actually goes full, then it's not a frozen shoulder because it's not stiff, it's weak. And then once he's in this position, you say stay in that position, stop me from pushing it in, and you can also test whether he's strong or not. Is it a partial tear and it's just weak, or is it a full tear and it's really weak and it's just going vroom when you push it in, basically? Yeah. But if it's active stiff, okay, there's something stopping it. So one is capsule, and it's stiffened up. What else can stop you moving your arm outwards?
Dislocation.
Yeah, good. So a dislocation. Any particular direction of dislocation?
Anterior.
Okay, 50-50. Posterior, yeah. So the most common dislocation is actually anterior, so it's what most people say. But it happens in epileptics. People will get electrocuted because as you contract, you internally rotate, and the ball comes out the back of the socket. Okay, and that can be missed. Olivia's seen some patients who've been treated with a frozen shoulder, and actually what they've had is a dislocated posterior dislocated shoulder that's been there for months and months. And that's quite disastrous because the head's starting to get eroded by that stage. So that's something that you've always got to keep in mind. Okay, and anything else that can stop you externitating? Older patient. Arthritis, yeah. So if they've got an arthritic joint, the inflammatory process causes a capsulitis, and again that produces a decreased range of movement in general. Yeah.
point, I'll just show you now, point being, so people who have posterior dislocations, they are rare to be honest, but they're people who suffer from epilepsy, they get electrocuted, or people who get electrocuted. And the reason is because your internal rotators are way stronger than your external rotators. So what happens is you have a fit, this happens, and if you go to the emergency department, they may give you midazolam, get you out of your seizure. They may x-ray your shoulder if you say it's a bit sore. If somebody who's inexperienced, which it does happen at least once a year in the UK, at least once a year, they'll look at this x-ray and they will not recognise there's an abnormality with it. It looks like the shoulder is in joint, but there is a sort of chicken drumstick sign or a light bulb sign or whatever you want to call it. There is this sort of symmetry of the humeral head. And if you get an appropriate axial view or even a lateral, you will notice on there that actually the cup is empty and the humeral head's at the back. And it does actually happen all the time. I don't see millions of people, but it's the sort of thing that you might actually identify. Things in the history, I'm epileptic, or I'm being electrocuted, I've got shoulder pain, and because I've seen at least 2 or 3 people that have presented some months down the line with